Welcome to Life and Sirens, Behind and on the Scene, a podcast by first responders. We're your hosts, Sophie,
Jamie,
and Aubrey.
The content provided in this podcast is for informational and educational purposes only and should not be considered medical advice. The views and opinions expressed by the hosts and guests are their own and do not necessarily reflect the official policies or positions of any medical institutions, emergency medical services, or healthcare organizations. Patient privacy is a top priority, and all discussions involving real-world emergency situations are de-identified and altered to ensure confidentiality. Always consult with a qualified healthcare professional or your local EMS protocols before making any decisions regarding patient care or medical practices. Listener discretion is advised, as some topics may include discussions of real-world emergency situations.
Welcome to our next episode of Life and Sirens. I think we're on week 5. This will be a full volume episode. We'll be talking about out-of-hospital cardiac arrest and the impact of working cardiac arrests on scene. We've had the experience of moving probably halfway through our career so far, moving from working them en route to the hospital versus now we work them on scene for at least 20 minutes. And we have seen some pretty impressive outcomes with this, and we'll be talking about a lot of statistics as we work through this episode, and if you need any of those references, I'll be posting them because I know there's some nerd out there that's gonna be like, well, where'd you get that from? Well, I'll let you know at the end of this episode. First things first, I think we want to talk about the importance of CPR, defibrillating quickly, and kind of making sure that we're prioritizing those two interventions. And I know that Jamie is really passionate about this, so I'm going to kick it off to her.
I think a lot of times we get on scene and we forget that there has been a lapse of time since that arrest. Rarely do we witness the arrest. And when you think about the amount of time that a human brain can survive without oxygen, without any significant damage, we look at about a 6-minute mark. Well, for the most part, a 6-minute response time is fantastic. We sit at about 6:30 to 6:45, depending on the month. So that 6 minutes is already passed. And a lot of times when you're talking about intervention, you look at the likelihood that hands-only CPR is going to be successful. That kind of runs out at about that 5-minute mark. And so ideally, you've had bystander CPR, and if they're doing hands-only, that is okay. Then we get there, and we need to focus on CPR number 1 and ventilation number 2. The problem is that when people are really jazzed and excited, ventilations tend to be every 3 seconds instead of every 6 seconds. Or if you're doing 30 to 2, in those 2 ventilations, you hyperventilate quite significantly, just a much larger volume than is required. And so those 2 things I think are super important. Also, people tend to get there and they want to do the most high-speed intervention first. So you get on scene, someone's doing compressions, and then immediately the highest level provider will grab their intubation equipment and be like, I'm getting an airway. There's a reason that's, the 4th thing that you do down the ACLS algorithm. There's a reason that 2 rounds of CPR happen before you consider an advanced airway.
Right, and let's remember that according to the AHA, for every minute without compressions, we're decreasing survival between 7 and 10%. That's a lot.
Yeah, and the chance of survival is already, it's not 100.
Right.
So when you decrease by 7 to 10%.
For every minute. That's just every single minute that you're off the chest. So.
What's an ideal, if you get through your algorithm, you're doing everything the way that you're supposed to. And then you determine that this patient needs a advanced airway. And you decide that that's going to be innovation. What does that look like for you? Are you stopping compressions? Are you continuing compressions? Are you moving this person? What does that look like?
Well, we are very blessed to have a protocol in place to work cardiac arrests on scene. We are also very blessed to have Lucas devices on every truck that we utilize enormously. So if any of you guys have ever had the pleasure of using a Lucas device and intubating with a Lucas device, it actually is not near as difficult intubating with the Lucas device than it is with manual CPR.
Turns out on manual CPR, we really overshoot the depth
Absolutely.
that's necessary, which causes quite a bit of airway movement as well.
Correct. If any of you do RQI, you already know about this. So to answer your question, while working that cardiac arrest, when you get to the point where, yes, I am going to place an advanced airway, I believe intubation is going to be the best route for X, Y, and Z. That's your time to set up your intubation equipment. You will continue compressions. You do it as close to your pulse check as you can, and hopefully successfully intubate, and then resume respirations every 6 seconds.
Absolutely. So if OROBs, either one, when you guys intubate, do you, now obviously there's a difference between like intubating during RSI and a code, but is there? So do you still use no DSAT? Do you still apply passive high flow oxygenation?
Absolutely. If we can maintain oxygenation, it obviously depends on the cause, the downtime. There's so many factors.
Mm-hmm.
Are we going to be able to ventilate this person and oxygenate them to a place where we're happy? And obviously that's not always possible. But if we can, oxygenate them to the best of our ability, it's going to give you, it's going to buy you some time, right? And then they've already been without oxygen for, we sometimes have no idea how long. So let's prioritize oxygenation over intubation. Like, we can oxygenate and ventilate very well a lot of the time without immediately jumping to some advanced airway.
Absolutely. Correct. So if you are a newer provider, or you don't have a lot of intubations under your belt, or maybe you do, but you're in a place that you're just like not super comfortable with it.
Right.
Do you still try to intubate them?
I think that we need to prioritize the best possible patient outcome over ego. And if you really think that you can't get that too, for some reason, I mean, you've thought it, obviously, new providers can have some confidence issues. I did. And sometimes we need someone to push us to be like, hey,
you can do it.
You can do it. But if there's something that's giving you a red flag that says, I just don't think that this tube is going to be something that we're going to be able to obtain quickly or easily, or without like some kind of extreme effort, then it is okay to use a different type of airway adjunct. In my opinion, I think that is something that has been pushed really far, like hard when we first got into EMS, was like just intubate over, the iGel, intubate over the King. What is the new one that we have?
AirQ.
AirQ. Intubate over this other advanced airway. But they're all advanced airways. Okay, so it's better than...
Yes. I think that there's a fine line between, or a couple fine lines, between intubating because you can. It's not appropriate. We don't just do things because we can. But
Preach.
Not intubating because you're afraid. Because sometimes that is the most appropriate airway. Sometimes this is a respiratory arrest. And establishing a secure airway is very important. Sometimes they have a just boatload of secretions.
Right.
And you're not going to be able to effectively protect that airway without intubating. But you also have to gauge that on your personal skill level, like your level of proficiency, and other providers on scene. So I know that I've encountered, whether it's CPR or whether it's just a respiratory failure, I've encountered airways that I took one look at this person and said, that is going to be hard. And thankfully, I have supervisors that are insane that I do not think have ever missed an intubation.
Insane in the best way possible?
Oh, yeah. So we've got Wendy, and this woman could intubate you from across a football field. I mean, she just doesn't miss.
Right.
And it is not that I don't feel like I'm proficient in this skill, but she is far more proficient.
I feel a lot of feelings about that because it's okay if you know there's someone who is far more versed and skilled in the intervention that needs to be performed to potentially save this person's life, to allow them to do it instead of you.
Yes. There has been airways that I have requested her attempt prior to me because I looked at it and I said, I don't think that my proficiency level is worth this try because I know she can get it. So why would we risk that I can't? In this moment, that's what the most important thing is. You have to balance whether or not you're requesting that out of fear or practicality. And in that moment, it was truly practicality. But I find that that's really hard for new providers because they're either one, so excited they can that they just attempt. And you start to miss the point of this intervention, which is to increase someone's likelihood of survival. And I have a hard time with that when they don't recognize or realize that there's going to be a higher level, far more proficient provider right behind you, or is still standing behind you. And for you to attempt that airway is reckless.
Absolutely. And there's nothing cool about you continuing to miss an airway when there's an option for a very successful attempt. There's nothing cool about that.
And when you're looking at something like CPR, when that isn't even the most important part.
Right.
Yeah, let's
That's
circle
why,
back to what's
circle
really
back,
important.
CPR and
Jesus.
defibrillation, that's what's saving
Yeah.
this patient. More than anything, defibrillation especially, that is how we get people back. So when we first get on scene, oxygenate, yes, but CPR and defibrillation, that's where we're gonna...
And oxygenate appropriately.
Right.
There are some decent studies that show that hyperventilation actually lowers your chance of survival. And pre-hospitally and in the ER, we are statistically really bad at oxygenating people appropriately. We almost always hyperventilate because we get too excited. And so be very cautious when you are the one in charge of ventilation that you're not hyperventilating, because that can decrease your venous return, which then can decrease your pulmonary perfusion. And then you're kind of just fighting yourself.
100%.
But if you don't ventilate at all, then you end up with huge CO2 levels that decrease your cerebral perfusion, and then you end up with a brain injury that is also non-survivable.
Yes.
So you really have to play both sides of the fence.
Well, and I think that a lot of the times we say, oh, CPR, this is like the easiest call you ever have, because there's the ACLS guidelines, you just go down the algorithm. But there is so much more critical thinking that needs to be happening when you get on scene for these calls, because when we just go down the algorithm, we skip a lot of things, and we just think, oh, we want a rhythm back, we want a pulse back. We give a lot of epi, we do a lot of things like this, but like your priority is not just get a pulse back. Like, we need to do everything possible to make this the most efficacious intervention slew of things that we're about to do to keep them alive. It's not about just like getting ROS.
Yes, because our goal is intact neurologic survival.
Yes.
And when you're looking at ROS rates, if you then turn around and you look at the neurological survival rates, like door to discharge, and kind of what that looks like for that person, it's not great.
Well, let's talk about ROS rates and how we have seen them change pretty significantly, I think, for a lot of us, which is interesting because I do have some statistics in here, but I don't think as impressive as it has been for us is reflected in some of these studies, which is interesting. But for my stats here, I have one study that was done, ROS rates of 23 to 24% for on-scene efforts compared to only 17% with transport. That was done in 2010. So maybe we didn't have the same equipment on trucks as we do now. But, I mean, I think all of us can say, like, there has been significant changes in ROSC and outcomes for us for the better.
Absolutely. Yeah.
We saw a wild improvement with our service, and we went to a mechanical CPR device. So we went to the Lucas at the same time that we started working cardiac arrest on scene.
Very big changes.
And so both of those things show significant improvement in your ROSC rates. And not because, I know that this is a sticking point for a lot of people, but not because mechanical CPR is inherently better than like provider CPR,
but continuous.
but it is more
too.
consistent.
Yeah.
And so I think the consistency really, if you have a bunch of very consistent, proficient providers that are used to always working together, then an argument can be said that it's actually better.
When it gives you
However,
opportunity for critical thinking, when you take one of those tasks and give it to a machine.
Absolutely.
Do you guys remember the days that we would bring people down on spine boards downstairs and like do CPR? While we
Exactly.
were
That
doing
is
that?
not uninterrupted CPR.
No,
that is
that
not
was
quality
crazy.
CPR.
No, I used to be, because I was oftentimes, I'm not like the teeny tiniest human, but I worked with a lot of very large men, and so I was often the smallest person on scene. And so I was tasked with riding the stretcher.
Honestly,
And-
though, I do love a good stretcher ride.
Me too. And I honestly kind of miss it a little bit because it felt really hardcore. However, my compressions were only good for
Right.
about 10 seconds, and then it was just, I was real afraid I was gonna fall off that thing.
Yeah, I mean, it is quite,
Right?
quite scary.
So, I mean, like, it's high speed and it's very Grey's Anatomy-esque.
Absolutely.
However, is it efficient? Is it more efficient than a consistent, continuous CPR device?
Right, and let's talk about the CPR device, because just because you're using the CPR device doesn't mean when you're extricating this patient from the home that they're continuing to get the intended and high quality CPR that that device promises.
Absolutely.
Because it is not supposed to be this person like hanging off of, you know, a spine board or a mega mover, things like that. It's supposed to be flat, on the ground, on a stretcher, on a hospital bed, up and down movement, especially with the Lucas. Like, you're going to have seal interruption. If you don't have every piece of this device secured appropriately, there's going to be interruption. So that's my soapbox. Just because they have a device on does not mean they're getting quality CPR.
Absolutely. And we know that because we have the Lucas device, but there are obviously other devices out there. And there's a couple that, like, one of the devices that's a full band that goes across the chest.
Autopulse.
There's a huge problem with people just sliding around in it.
Absolutely.
And so when you try to move them, they fall off that weird half backboard, and it just is really difficult. And then sometimes the band slides up or down, and you're constantly repositioning your patient. When you look at the Lucas device, it's very top heavy. And so if you do reposition or move your patient at all, they are not attached to that backboard. So when the plunger comes off of them or comes up, that's the only thing that secures them inside of that device. And so if you don't have the arm straps on and you don't have the neck strap on,
Gotta have that neck
Gotta
strap.
have a neck strap.
then that device starts to move a lot. And you can watch the plunger travel if you don't have it
Absolutely.
properly secured. And what is the one piece of equipment that is the Lucas device that I think we kind of already said it's a spoiler alert, that nobody uses and everybody should?
The neck strap.
The neck strap. It irritates me
It is important.
just high heavens when we get there and a Lucas device is already on by another agency or whoever it is, or even if it's one of our crews, and you'll be like, where's the neck strap? And they're like, wait, what? I don't
It's
know.
kind
We
of
lost
just
it.
as silly as intubating someone and not inflating the cuff.
It is just as silly
It
as
would
that.
be, because doesn't that just seem like a step?
That's just part of it. It is
Right.
part of it.
And proficiency in your own skill set is very important. But also, proficiency in the most basic levels of your skill set, proficiency in the skill sets below yours is very important. If you cannot properly apply a device, problem. If you cannot properly perform a procedure to the full extent of that procedure, problem. And it kind of goes back to when we were talking about the highest level of care, and not even necessarily by means of licensure, but sometimes that is just by means of efficiency. Like,
Yeah.
have I seen this person do something better than me?
Know yourself, know your skills, know what is best for that patient. And
Absolutely.
sometimes what you want to do isn't always what's best. Sometimes we either have to do something that we're really scared to do or say, hey, I need help.
I'm a critical care medic, and Aubrey as our paramedic, and we're partners. And there are skills on our truck that she's just better at than I am. And so there are things that she'll do that I won't do.
Don't make that face.
But it's not necessarily it's about your level of proficiency and knowing yourself, because you don't always know the other providers on scene.
No.
So you have to know yourself to be able to ask, like, hey, does anybody else feel more comfortable with this procedure than I do?
Absolutely.
If you feel like you're doubting yourself on it.
For sure. So we've talked about kind of like why we really love the idea of working and the reality of working codes on scene. We talked about the Lucas. We talked about intubation. And I think one thing I just want to mention is that how critical and unstable these patients are. Just because you get ROSC on scene does not mean that your patient has now suddenly become stable. That is still very critical. And if anyone who is listening has been doing medicine of any type for any amount of time knows that when patients are really critical and we move them, they tend to either significantly decompensate or code.
Yeah.
So one thing that is awesome to think about before you're trying to transport too early or start making decisions about where you're going to transport to is, have I gone through my H's and T's? Have I decided that I've done everything on scene to help this patient become as stable as possible. Things like pressors, pacing, whatever it may be. Have I done these interventions before I pick them up and throw them somewhere else? Because patients in the hospital, we roll them over and they code. So think about having to move a patient who was just in cardiac arrest outside of a hospital, and now we have to put them on a mega mover or some kind of spine board and like take them downstairs and take them down hallways. It's just so ridiculous.
And oftentimes in those moments, we actually miss the rearrest.
Absolutely.
Because we're busy curing them.
So why don't we do everything we can to prevent rearrest? It's kind of like, have you ever heard a firefighter say there's no such thing as a rekindle? You just didn't do everything that you needed to do, right? So that's kind of how I feel with Rosk. It's like, obviously, there are things way beyond our control. There's interventions that we cannot perform on scene, but we need to make sure before we're moving people, we do everything that we can.
Absolutely.
Yeah.
Keep them alive.
I think that an interesting train of thought is we hear all the time, like, oh, we just treat them and eat them. We just load and go. Where our job is to take them to a hospital. But, like, the foundation of paramedicine and EMS was that we bring medicine to the people, right? We
Absolutely.
find people, we treat them on scene to our highest ability, we stabilize them prior to moving them, and then we transport them to a facility with higher level of care. And that absolutely applies in cardiac arrest. These are, by definition, the sickest patients that we come into contact with.
For sure.
And it is asinine to think that once you get that heartbeat back, then it is the green light to move. Because there's a reason that they arrested, and there are probably things that we can do to prevent a rearrest.
Right. And the reason they arrested probably wasn't because they weren't getting cardiac epi pushes.
Well, let's hope not. My God.
And you look at the patients that we encounter that we are the most worried about, and it is those patients that are peri-arrest, that are very close to arresting. But then once they do arrest, we're like, another code.
Yeah.
And then you just run it like you're not concerned. Well, then if you get ROSC, if you do your job well and everything kind of falls on your side, you get ROSC. And then all of a sudden,
That should be the most difficult part
we're
of
back
your call.
Yes, we're back to the sickest patient
Right.
that we've ever had again. Well, the part in the middle that we just don't consider them the sickest patient it's a very interesting thought process, and I think it stems past EMS and into the ER as well, because everyone's like, we'll just code them. But you have to think about why they arrested, what that looks like, and that can factor into your transport decision as well too. We talk a lot about working codes on scene, which I think for the vast majority of the population, that is true.
Right.
And we're not talking about hours on scene.
No, AHA and EMS protocols currently recommend 20 to 30 minutes of on-scene intervention.
And that really gives you enough time to get everything squared away, to get all of your interventions squared away.
Calms you down.
Yep. It helps you to go through some differentials. If this is like a 60-year-old male and you have his wife as the caller, says he looked pale and was kind of sweaty, came in from the field and grabbed his chest and said, "Bertha, I don't feel right," and then fell to the ground. That's a pretty high indication based off this man's lifestyle, the things happening prior to arrest. This is probably cardiac related. That sounds like a massive MI, right? Yep. And you need to be considering that when you're considering your transport time, when you're considering your transport destination in the event that you get ROSC, and even maybe prior to that. Where does this person need to go? They need to make it to a cath lab. Right. And when you start to look at those,
I was just gonna say, isn't it silly? Isn't it silly that you get to a peri-arrest patient who is like, let's just say, probable respiratory failure? They end up coding. You work your tail off. You get ROSC, and then all of a sudden now you're just doing H's and T's, even though you already know. Now you're like, H's and T's. Let's check. Yep, Narcan. Let's check a blood sugar, even though you probably already know.
Right, because DEC, MAG, albuterol, that's not in your cardiac arrest algorithm.
Nope, it is not.
But it is in your respiratory distress algorithm.
Yes, I was talking to a new medic at one point, and actually was not out of school yet, but he asked me, he said, we can pace them? So once they're alive again, you just go to the right protocol.
And when you start to look at ROSC rates, what you need to be concerned about post-arrest, you still need to be concerned about their reperfusion injuries, the level of free radicals that they have going on. Like, you need to be aware of those things. There has to be a critical level of thinking where you recognize that because they had arrested, this patient is going to have an increased amount of problems that they would not have if they had not arrested. However, a lot of those things we can't address pre-hospitally. So you need to be aware they exist, try not to make them worse, but then go down the appropriate algorithm. If now they're bradycardic,
pick a new algorithm.
pace them.
Yep.
Now we're going through bradycardia. If they were respiratory failure that led into an arrest, you get ROSC. Well, now they're still respiratory failure, and you have to address that. If you have an established an airway. If you have an RSI.
Yes.
You know, you have to start going down these other algorithms. And I think that we forget to talk about that cardiac arrest is not separate. It is the end result of a
nobody dies
disease process
from cardiac arrest.
Yes.
I mean, yes, but like, you know what I mean? Like,
It's actually my
that's not
favorite.
your, that's not the, like, that's not what they put on your death certificate.
It's actually my favorite AHA like saying, where it's like 1 out of every 3 people you know will die of cardiac arrest. But I do think it's
It's just a
funny
byproduct.
that we talk
Right.
about cardiac arrest like it's a separate illness. We're like, oh, well, they suffered a cardiac arrest. That is just the culmination of whatever disease process.
Yes.
It is the completion of said disease process. Whether if that is an acute disease process that we can fix, sometimes it is a chronic disease process. It really depends. But to think of it separate from those things, it's not. There are things specifically that we do to address cardiac arrest, but we're just getting you back to the end
Right.
of that disease process where we can maybe change the outcome a little bit. And I think when you consider it in that form, it means that when you get on scene and you start providing these critical interventions for cardiac arrest, you also need to be going through differentials. You still need a med history. You still need home meds.
Absolutely.
You still need to know what they were doing in the last hour. These are all things that people they just don't do. I mean, and it's high speed and there's a lot going on, but how many providers do you know they get to the hospital and they're like, I don't even know who they are?
Yeah. But waiting those 20 to 30 minutes of on-scene resuscitation gives you so much opportunity. And when you have the Lucas devices and things like that, it really just slows down and calms down your scene like exponentially.
Mm-hmm.
And just think about how chaotic it was. And I'm sorry for the people who are still transporting cardiac arrests. But
Sorry.
think about how dangerous and chaotic that was, not only for us but our patient. Like,
It was absolutely crazy.
Chaos.
Remember when you would just get to a residence, you would find a person who has suffered a cardiac arrest. You would load them up to onto your stretcher as fast as you possibly could. You would get in the back of the truck. It would just be a whirlwind of wrappers and medical devices.
There was always someone attempting to bag while you're running with the stretcher.
Oh,
There was always someone
absolutely.
attempting CPR.
There was like half a palm
Yeah.
on the chest until
think
you got
about
to the truck.
percentage of time off the chest.
Yeah,
Mhm.
it's not good.
Yeah.
And then once you finally made it to the truck, there's at least 5 providers in there. There is, just a confetti array of wrappers. There's medical equipment everywhere. And then inevitably, the one who's leading the call says, all right, let's go to the hospital. And then you are just hanging on for dear life
Yes.
on
and-
your way to the
Okay,
hospital.
does anybody remember the time that it was very, very new EMT, but I was out on my own. I was doing chest compressions in the CPR chair, and there's a firefighter across from me, and the person that was driving took a turn a little hard, and I headbutted a firefighter in the crotch.
I do remember that call.
Okay, mortified, first of all. Second of all, I had to stop CPR because I was in the lap of another person, and then he could not do CPR because he was
In pain.
incapacitated.
Incapacitated.
Uh-huh. I often, especially once I got my medic, because we were still doing this when I first got my paramedic, I would be ventilating. So we would have intubated, got a secure airway, I'm bagging, and inevitably my other hand would be on a firefighter's belt. So that while they were doing compressions, they did not just fly around the truck. Because we all know that like ambulance legs are a thing.
They
It's
do
like
not have
sea
them yet.
legs. Ambulance legs are a thing. It takes a long time of standing up in the back of a moving truck to really be able to do it well. And then oftentimes somebody else is driving that is not used to driving with people standing up in the back of a truck. And they will just fly into the walls, into the corners, into you. I mean, it is wild. Or they will have such a wide stance that nobody can move around them because they are like hunkered down.
Yeah, it's one or the other.
Yeah. But it's just chaos.
And I think another thing that we can think about when we decide not to immediately transport, and this doesn't necessarily apply to us because we serve a metropolitan area with a hospital that is very capable. But for those agencies that only have access to like a critical access
center,
with like 6 ER rooms, things like that. Like now that we have ROSC, now we might be able to go to that, cardiac cath lab, that ECMO capable center, whatever it may be.
Yeah, consider, is that critical access center more equipped than you? Is there anything that is going to happen for this patient that you are not actively doing? Now, if the answer is yes, and they need more interventions, they need an intervention that only a physician can perform, things like that, then absolutely go there. But a lot of times with a lot of these critical access facilities, the answer is no. And they will either fly that patient, which may be the most appropriate intervention, and that could be exactly what needs to happen, or they will do chaotic things for an hour and then ask you to take them anyway, with not a lot having changed. So consider that in your system. Are you actually pretty comparable to your closest facility, and is it worth venturing onward? Can this patient
what are the risks there?
Handle that, and you also look at when you're considering transport times, your on-scene time, things like that. There's a higher level of thinking that comes with this, but consider, is this patient an ECMO candidate? Do we have an ECMO capable facility? What does that look like? If I am in a good place and I'm kind of set in our, resuscitation efforts and we're only 15 minutes in, are we to a place where we can, effectively move because I think this patient might be a good candidate for ECMO based off age, disease process, things like that? And then where do you go? Do you notify that facility to call an ECMO team from another hospital, things like that? But there is far more to cardiac arrest than just ACLS. You can think through it with depth, and you can actually get these patients to places where their survival will change.
Absolutely.
Which is pretty cool.
Have y'all seen where they have started cannulating people for ECMO in the field?
In the field.
Did we see that?
That is so cool.
We recently had an in-service and had a speaker come.
Yes, they have a pre-hospital ECMO team, and they will go to a on-scene resuscitation, and they will cannulate somebody for ECMO in the field.
Incredible.
So cool.
I mean, they're doing it in very few places in the States, but they are.
Yes, and the patient has to hit X, Y, and Z, boxes, but it's gotten these EMS crews, because this is not, the ECMO team is not just responding to every cardiac arrest. These crews have to
be able to communicate and understand.
I think this person's a candidate. And I'm sure there's probably dispatch questions and things like that as well that kind of like start the ball rolling.
For sure.
But that is insane.
Mm-hmm. It's crazy.
What about
so cool.
When patients, we have checked all the boxes and we have been working for 30 minutes. We've had no changes. I think a lot of people, at least for me, I was really nervous about having to say, okay, we are going to terminate resuscitation efforts, especially in front of like family, bystanders, whoever it may be. Let's talk about what we do next when transport is not the option and it's to, unfortunately, terminate your efforts.
I think that, as always, amen and amen, EMT school, scene safety is always priority. So if you're ever in a situation where you feel like that is going to go badly or it's already going badly on scene, obviously you always have the option to transport that patient, right?
For sure.
This is going to be another Chris Smith shout out, but he mentioned something the other day that I really loved. He said that he tries to, on every cardiac arrest that he ends up terminating in the field, that he likes to take a moment of silence. It's closure for everybody that was involved in the cardiac arrest, anybody that's on scene, family, bystanders that's witnessing it. It's just a good moment of closure for everybody.
I like that too. One thing I also like to do is to say, okay, we kind of wrap back around. We say, okay, we've done this, we've done this, we've done this, and we've done this.
Yeah.
It has been this amount of time. We had an unknown downtime. We're continuing to remain in asystole. Does anybody, all providers, whatever license level, does anybody have any more recommendations?
Mm-hmm.
Because I feel like sometimes as a lower level provider, it can feel like, oh man, like why do we just stop? Because maybe they don't understand completely, or maybe they understand something more than I do and they saw something.
Mm-hmm.
Yeah.
Like, oh, well, we didn't do this.
Like, didn't check a blood sugar.
Yeah, exactly. I mean, still.
Yeah, absolutely. I think that the first cardiac arrest, I ever witnessed in hospital. I think I was like in my EMT clinicals. I witnessed in hospital, and the physician did that, which I think is pretty standard for most
And
physicians.
I think that's something we definitely need to do.
Yeah, and the nurse actually had a suggestion. The physician said, okay, like, let's do it.
Right.
And I liked that was inclusive. And so I do the same thing on cardiac arrest because I think that it gives everybody some closure. I like Chris's moment of silence because if anything, it shows the family that you have respect.
Absolutely.
That you're respectful of their loved one, that you're not just like writing this off, to give them that moment of everybody kind of culminating that effort.
Right. And for people who maybe that doesn't work so much with,
Mm-hmm.
and I'm that kind of person, I want to know what you did. So that's why I like to say, these are everything we did.
Mm-hmm.
We've exhausted all efforts. We've called the doctor. They agree
Yep.
that this is,
They
unfortunately,
agree that they do not have any further interventions that would benefit this patient in
Right.
hospital either. I think making that decision sometimes hard.
the first time I ever called it was with Aubrey. By the end of this, we did also transport to the morgue, which is something we do at our service. I know a lot of places do not do that, but we do have the opportunity to do that when it's appropriate. And by the time we were leaving and we had loaded this patient or decedent now into our truck, they were thanking us.
Mm-hmm.
It is, I think it's so important for the family to see everything that we just did. I do.
Mm-hmm.
Yeah.
I really do. And I would want that.
Because there is this gap that they miss when we transport immediately. And so other than like the clear evidence that it is better for patient outcomes to work on scene, it's also better for families. And to some degree, once you start talking about death, a lot of what we do is for the living. It's not necessarily for the deceased.
Absolutely.
And to some extent, like, you consider that with on-scene codes. Family can watch if they want to. If you're a provider that kicks family out, I would ask you to strongly consider, if it's safe, to allow family to remain on scene with you if they so choose. Now, it's a decision they get to make, but to have that option, like, to watch these efforts. So when you do end up calling it, if you end up calling it, if you don't end up transporting, if you terminate on scene, they can look at you and know that they've watched you with all of these efforts. So I think that I like that you remain on scene and let family watch and all the things. Where's your line? When do you start thinking, what are we going to do? Are we going to transport? Are we going to terminate? Where are we at?
I think that I start in the very beginning. Like, as soon as we get there.
Yep.
Because we need to know, like, obviously, like, is there anything on scene that we don't have that absolutely is going to save this person? For our service, we don't have blood. So if this is something that the only thing that is going to get them back is
Blood.
Blood and reperfusing them, then we might need to consider transporting a little earlier than we may on just this patient went into VTAC, suddenly collapsed, and it was because of some cardiac event.
There's some really cool studies that are coming out right now that are about not doing CPR on trauma arrests, but instead giving epi and giving blood, which is really interesting.
I would love to dive into those.
To check them out. They mentioned it at EMS World, and it was like, do not do CPR on a trauma victim. That's basically how, like, you make it all worse. But it outlines, like, the things that you can do. It's very cool.
Yeah, I like that too. I think we have a lot of work to do in the trauma resuscitation when we've reached the point of cardiac
Follow your
arrest.
local protocols.
Yes, that is one thing I did want to close things out with. Like, we are very lucky. We're not even the most progressive, that we do have progressive protocols with cardiac arrest. But always, follow local protocols and ACLS. But don't just stop with ACLS. Use critical thinking. Call a doc when you need to. And that's the beauty of working it on scene. You do have more time to phone a friend, i.e. the doc, and try to make some decisions that are going to be best for the most effective outcome. Not just, did we maintain a pulse to the ER? Did this patient maintain a pulse and brain activity and live somewhat of a effective life?
Yeah.
afterwards?
Remember that your goal of CPR and resuscitation efforts is not ROSC. It is neurologically intact outcomes. And I think if you can shift your thinking to neurologically intact outcome away from ROSC, it adds value to your efforts on scene.
Most definitely.
Just a little disclaimer that I want to put in here. Don't get discouraged when you get ROSC on a patient and you find out that they lived in the ICU and then they eventually passed away. Because, and especially traumas, those are the biggest candidates for organ donation. So, like, it's not a loss.
It is a loss, but not completely.
And we talked about how a lot of what we do is for the living, the ones that are going to remain left behind. And sometimes, even though we look at it as it was not a neurological outcome, we got ROSC, they died in the ICU one day later, after family signed a DNR, like, maybe we just shouldn't have done it. But consider the people that got to come say goodbye.
That's
the family that got to hold their hand, watch them go peacefully. So just remember that sometimes there is value there as well.
Absolutely, or even for the family member that initiated CPR.
Sometimes you just give families closure with that effort. And so remember that even though for patient-centered care, neurological intact outcome is the only really real success, when you look at ethics and morals and your own, personal well-being, look at the lives that you affect of the people that are still left behind, where they get to spend some time with their loved one. If they do end up in the ICU for like a day.
Right,
and
it's
pass.
not for nothing.
Yeah, there's always a silver lining to your efforts, even if it wasn't neurologically intact outcomes.
Right, and for every ROSC that we obtain with, modern medicine and new science, that's something that can, go into the logbook, go into a case study to say that, this was effective. So there is also that side of things, like the science is there, we're doing everything right. What else can we do?
Oh, for sure. Yeah, like we got ROSC at 1 hour, but they got 12 EPIs.
Right.
Before they ran out, and so they didn't work out at the end. Right, so like it does give opportunity for research and studies and retrospective studies and things like that as well.
Does anybody have any last closing remarks?
Fast is slow, and slow is fast.
James' favorite phrase.
My favorite phrase.
I mean, that's very poignant.
When you start your resuscitation effort, follow your algorithm. Do it methodically and do it very well. And insert critical thinking where appropriate and available. But do not rush a cardiac arrest, because you will almost always find that you have decreased that person's likelihood of survival by doing so.
Well, thank you all for listening to our episode on out-of-hospital cardiac arrest. We are all very passionate about this and very excited about where this is going. Don't forget to follow us on Spotify, Apple Podcasts. You can visit us on Facebook, maybe the Instagram, or even TikTok. And we'll see you guys next week for our fireside chat.
This has been Life and Sirens, produced by 3 nerds trying to bring you content that you might actually care about.